This program is a presentation of UCTV for educational and non-commercial use only.
My name is Margaret Chesney. I'm the director of the Osher Center, and I want to welcome you back to the second in our series. This is a mini medical school class or course that's focused on women's health, an integrative guide to supporting and sustaining wellness. So anyway, I'm just going to do a brief introduction and then turn this over to our wonderful guest speaker. Our series is focusing really on integrative medicine, so I wanted this evening just to give you a sense of what that means here at UCSF and around the country. Earlier today I was at the consortium meeting, which is a meeting of, now there are 50 major academic health centers in the country that all have centers of integrative medicine, and it was a meeting in Madison, Wisconsin, of those 50 centers all getting together that do integrative medicine. You're going to say, well, what is that? Integrative medicine integrates the very best of evidence-based conventional or Western medicine with what has often been thought of as complementary medicine. But it's more than that. It focuses also on the whole person, mind, body. We talked about this last week, that if you see an integrative physician, and I think you're going to hear a person who has that philosophy tonight, Dr. Walsh is not going to look at you as just bones, but she's going to see a person that is skin and bones and has a life and has, you know, a family, a whole person, mind, body, and meaning in life, or spirit. I sometimes think of spirit as sort of what we find meaningful in our lives. Integrative medicine also really emphasizes a partnership between practitioners, patients, and families. And I say practitioners because integrative medicine clinicians often think in terms of teams, and working with you and encouraging you to maybe consider taking a yoga class, as Rita Redberg did. And they might also think that you might want to check in with a dietitian and learn more about diet and how that might influence, and we'll think about tonight, for bones. So they think about a partnership, and I often think of the patient as really the sort of the lead person in the team, because if it weren't for patients, we wouldn't be here. So you're very, very important to all of us. You're really the person that makes this all work. The other part of integrative medicine is a stepped approach. There's an emphasis often on trying to do the less invasive things first, see if we can get a person's blood pressure under control by maybe helping them lose weight or change their diet. Always looking, as I mentioned last week, just in case there's something else that might be going on, always with an eye to, you know, is there something here that we need to think about in terms of a more aggressive approach? But if there's not, trying to stage things in terms of lifestyle first, and also tailoring treatment to fit a person's lifestyle. You heard that last week. I think you're going to hear that again tonight, of people offering, wonderful physicians will offer you choices. They'll say, well, you could do this or this. They're looking for you to pick that which is really going to fit your lifestyle, because if it fits your life, you're more apt to do it. So if you're a person who loves to swim, swimming is a good exercise. If you're a person who likes to walk, birding, likes to be out in the wilds, then walking is better. Maybe you're a person who likes to bike. The idea is to stay active. We might even hear, I think, tonight some specifics about types of activity. But I just wanted to give you that idea of what is integrative medicine. Is there public interest in this? And the answer to that is yes. There was a survey in 2002 that showed that 36% of American adults, and this was a very carefully done survey where they counted every household, every mailbox, and randomly sampled everybody. And then when I was at the NIH, I funded a repeat survey using the same questions 5 years later so we could see if there was an increase. And it had gone in those 5 years to 38%. That doesn't sound like a big number, but it represents the entire population, so that reflects millions and millions of people had started doing something integrative in the last 12 months. So this is a third of the people. Many of these people, it's voting with their own pocketbooks because some of this isn't covered by insurance. The other thing I added in 2007 was to give us an idea of what's happening with people under 18. Are young people using integrative medicine? And we found out, for the first time, we had no data anywhere in the NIH. We found that 12% of young people are using some form of integrative medicine in the last year. Usually, they asked questions of the parents. And often it's things like echinacea for kids or probiotics, encouraging kids to have yogurt and so forth, things like that. Just to give you kind of a perspective. And the NIH, we actually calculated in a very conservative way what this is costing people. And the Americans spent $33.9 billion in 2007 on health and wellness using integrative medicine. So that's just sort of a little bit of an introduction to bring you back to this world. We heard last week Women's Guide to Heart Health, and tonight we're going to hear about building better bones, integrative approaches. And then next week we'll hear on advances in the prevention and treatment of breast cancer. So I want to introduce our speaker tonight, and it's Dr. Judith Walsh. Dr. Walsh is Professor of Medicine in the Division of General Internal Medicine here at UCSF. She is a primary care physician at the UCSF Women's Health Primary Care Practice, which is part of the UCSF Women's Health Center of Excellence, which is one of the centers around the country that is heralded as offering excellent care for women. After completing her undergraduate education at UC San Diego, she received her MD and Master's of Public Health from UCLA. She completed a residence here in internal medicine at UCSF, and we think that that's when we probably met. And that was followed by a special fellowship in clinical epidemiology at San Francisco VA Hospital. Her areas of research are cancer screening in women's health, and she's been funded by the American Cancer Society and the National Cancer Institute to conduct research on increasing rates of cancer screening. Remember last week we heard about screening and how important screening is, and sometimes it's not done appropriately. We have another expert on that here tonight. She's also critically evaluates new technologies for the California Technology Assessment Forum, and there are all these new technologies coming out in medicine. She's a national expert on women's health and has worked with the American College of Physicians and the Society of General Internal Medicine to conduct annual reviews of important women's health topics and then present those reviews to practicing physicians so that they can be kept abreast of the field. Earlier this month, for example, she presented an update on women's health at the National Society of General Internal Medicine. They have an annual meeting, and she was a guest speaker to give an update on women's health there. So we are very privileged to have our own expert on women's health to speak with us. This is Dr. Judith Walsh, who will talk to us about building better bones, integrative approaches. Judith.
Thank you, Margaret. So tonight we're going to focus on the bones, and we'll talk about osteoporosis. We'll start with what the definitions are of osteoporosis. We'll talk about what the risk factors are for osteoporosis and what the protective factors are, and we'll specifically focus on what you can do, what are the risk factors that you can modify. Unfortunately, some risk factors we can't change, such as getting older, but some risk factors we can, so we'll talk about that. Then we'll talk about prevention. We'll talk about screening, and as Dr. Chesney alluded to, there are appropriate and not so appropriate uses of screening, and we'll talk about when to decide about screening for osteoporosis. Then we'll talk about treatment, both non-pharmacologic and pharmacologic treatment issues, and then we'll talk about some emerging issues in osteoporosis. So first of all, as I'm sure all of you know, the reason we worry about osteoporosis is not so much that people have symptoms just because they have osteoporosis, but because if a woman has brittle bones and falls, then she can have a fracture. So osteoporotic fractures is what we worry most about. Women can get them from falling, and as you probably know, vertebral fractures, which are the fractures in the spine, which the picture that Dr. Chesney had up here earlier of the woman with the sort of the hunched over appearance, what we call the dowager's hump, that actually comes from fractures in the spine. So those can actually happen spontaneously. So both hip fractures, which is the one we worry really most about, many women who have a hip fracture have subsequent complications and a loss of physical independence, and vertebral fractures are associated with premature mortality. Bone strength, and we'll talk a little bit about that tonight, is measured by something called bone densitometry, and we'll talk a little bit about bone mineral density. So just looking at the big picture, more of half of white women will have some kind of fracture. The lifetime risk of a hip fracture is about 16%, and the lifetime risk of a vertebral fracture is about 33%. Hip fracture is the thing that we worry most about. I imagine if we were to take a poll of people in the room, that probably many of you have known somebody who had a hip fracture and who had some kind of subsequent functional decline or even died as a consequence of that. About 20% of hip fractures will lead to death in a year, and about half of those who survive will need some kind of help with their activities of daily living that they didn't need before they had the hip fracture. A vertebral fracture, which is the one I was talking about in the spine, can often come up suddenly without trauma. It can be just found incidentally. For example, if the woman has an x-ray for another reason, it's just found there that it happened. Or it can result in significant pain, which usually resolves in about 4 to 6 weeks. So let's talk a little bit about the definitions and how we decide what's normal and what's not normal bone mineral density. Now, a sobering thought for me, and I'm guessing for many people here, is that we all achieved our maximum bone density at the age of 30. So after 30, it's kind of downhill after that. So when we compare bone mineral density and when we look at what's normal and what's not, we compare it to the maximum bone density of a young adult woman. So if you might remember a bell-shaped curve, which you've seen where you have the average and then things going out on either side, a bone mineral density which is no more than 1 standard deviation below the mean of a young adult woman is considered normal. You've probably all heard of osteopenia and osteoporosis. So penia in medicine means less. So osteopenia means some less bone density, and that's a bone mineral density that's between 1 and 2.5 standard deviations below that young adult mean, below that 30-year-old mean, which is sort of the ideal bone mineral density. And then osteoporosis is defined as having a bone mineral density more than 2.5 standard deviations below that mean. When we talk later, we'll talk about some of the differences of treatment options for women with osteopenia and osteoporosis. As you can imagine, women with osteoporosis are at significantly higher risk of fracture than women with osteopenia. So as I said, the biggest risk factor, unfortunately, the biggest risk factor for almost every disease, with the exception of cervical cancer, is getting older. And unfortunately, it's not anything that we can do anything about. But the biggest risk factor for osteoporosis and for having a fracture is getting older. Gender, as you also know, that's why we talk about this in women's health. Men can get osteoporosis, but women are at higher risk. Having a history of having had a fracture already, basically anytime you've had anything, your risk of having that thing again is higher. Femoral neck, which is the top part of your femur, the big bone in your leg, which is around your hip, bone mineral density. So if that bone mineral density is known, that predicts your risk of fracture. Low body mass index, which basically means being skinny. There's a lot of reasons why having a high body mass index is not good, and obesity, as we all know, there's an epidemic and there's a risk for a lot of things. However, one thing that obesity is good for is your bones, partly probably because if you fall, there's more cushioning, and partly because the muscle strength and the pull on the bones probably gives them some strength. Use of oral glucocorticoids, so that's steroids. We all know about steroids when we think about, inappropriate use in athletes. But of course, many of you probably know there are many appropriate uses for steroids in medicine and many diseases that we treat using steroids. And having too many steroids for too long increases your risk of osteoporosis. A parental history of a hip fracture, so if any of your parents had a hip fracture, that increases your risk. Smoking, we heard about Barack Obama and reducing his heart disease risk with smoking. He's probably not thinking too much about his osteoporosis risk, but indeed he would reduce his osteoporosis risk with smoking too. And that's a very modifiable risk factor. And then drinking more than 3 alcoholic drinks per day increases your disease of many things, but the one we're talking about tonight is osteoporosis. So what are some other risk factors that aren't in the WHO risk assessment FRAX tool? So low calcium intake, there's been a little controversy recently about calcium. We'll talk about that tonight, but it has been shown that low calcium intake is associated with low bone mineral density. Vitamin D insufficiency, oh my goodness, vitamin D is like the cure for all that ails you, and we'll talk a little more about vitamin D tonight, but low vitamin D is indeed associated with low bone mineral density, and having more vitamin D does help your bones. Not so clear that it helps all the other things that it's been associated with, but pretty clear that it helps your bones. Low physical activity. We'll talk a little bit about physical activity, but we just talked about exercise, and one of the many things it's good for is your bones. Thinness we talked about. Urge incontinence, we'll talk a little bit about urge incontinence. I see that you have a whole lecture on mind over bladder, so you'll hear more details about that later. Impaired vision, as you might imagine, impaired vision associated with falling, increased risk of fracture. Prolonged amenorrhea. So amenorrhea is a time period when a woman does not have her period. Typically an issue of in younger women, for example, young athletes or young women with eating disorders, but having a long time with not having a period increases the risk of osteoporosis. For women who take thyroid medication, there are many appropriate reasons to take thyroid medication, but if it's not monitored correctly, and if a woman takes too much thyroid medication, then that can increase the risk of osteoporosis. And very importantly, and we'll talk a little bit about this, is falls. If you fall, then you have a significantly increased risk of having a fracture. So age, as I said, the risk of hip fracture increases with age, but even if you look at two women with the same bone mineral density, one who's 75 and one who's 55, the 75-year-old has a much higher risk of fracture. Vertebral fractures, the fractures in the bones in the back, even if they were just sort of found by accident on an x-ray, if you have them, you are at very high risk and a pretty significant risk of having another fracture. Falls. The majority of osteoporotic fractures result from falls. That's why we worry so much about what we can do for falls and how we can prevent falls. So what are the risk factors for falling? As you can see, a very long list. But I think when we're thinking about what are the things we can do something about, things we can think about are people who have impaired transfer and mobility. Medications is a big thing that I think about if I see a patient who's falling. Is he or she on any medications that could be increasing that risk? Poor vision and use of bifocals. If you can't see well, your increased likelihood of falling. Cognitive factors, urge incontinence we'll talk a little bit about, poor balance, not having assistive devices in the bathrooms, having too many throw rugs around. How many people have tripped on a throw rug and fallen? I won't take a poll, but you can just think about that quietly. Low-level lighting, having things in the way, slippery outdoor conditions. The classic story, when I was in medical school, there's a typical fracture of the wrist that people can get. And I remember being asked this question on my surgery oral exam, and I was so proud that I knew the answer. You know, an elderly woman goes outside in the snow to shovel the snow, and she slips on ice and falls on her outstretched hand. What kind of fracture does she get? So it's a Colles fracture, by the way, in case you're wondering. But in any case, things to think about when we're trying to reduce fall risk. So what can we do to prevent osteoporosis? So estrogen use, I have to say this very carefully, we don't prescribe estrogen primarily to reduce the risk of osteoporosis, but if a woman is taking estrogen for whatever reason, it does protect her bones. African American women have a lower risk of osteoporosis. Being obese we talked about, calcium we talked about, exercise. Thiazide diuretics, if anybody here has high blood pressure and takes hydrochlorothiazide or diazide, which is a commonly prescribed first-line drug for hypertension, be assured that that's doing something good for your bones. So which of these things can we do something about? Beta blockers have been associated. You know, we don't, again, prescribe beta blockers primarily to reduce osteoporosis risk, but they've been associated. One of the things that I'll mention, and I'll try to reiterate, there are some things that we have pretty clear evidence are causal associations and some things that have been associated. And so, for example, beta blockers and thiazides, they've been associated with less osteoporosis, but you wouldn't go see your doctor and say, can I start a thiazide diuretic to reduce my osteoporosis risk? But if you're taking it for some other reason, good to know it might be helping your bones. Fracture and subsequent risk. Any fracture is associated with an increased risk of 5 to 10-year mortality. Not just associated with another fracture, but an increased risk of 5 to 10-year mortality. And then if you have another fracture, then it increases your mortality again. So the message for me when this study came out was that we really need to pay more attention to non-hip and non-vertebral fractures. We tend to only worry, or mostly worry as physicians, about hip fractures and the fractures in the bones, in the back, because those are sort of the classic osteoporotic fractures. But any fracture, particularly in a woman with osteoporosis, is associated with an increased risk of mortality. So smoking, I'm sure I don't have to convince this group that there are lots and lots of reasons to quit smoking, starting with heart disease, cancer, but osteoporosis prevention is another reason. People who smoke lose a lot of bone mineral density, 50% increased risk of hip fracture, and for lots of reasons, any woman who smokes needs to quit smoking. We talked about the over-replacement of thyroid hormone, that if you're taking thyroid hormone, and there are many reasons that somebody might be taking it that are very appropriate reasons, you want to be sure that you're getting the right amount and not too much, and because that can increase your risk of osteoporosis. Poor vision, women who needed glasses or who had better glasses, or who had cataracts have an increased risk of hip fracture. Urge incontinence. You'll probably hear more about this in a couple of weeks in terms of the mind over bladder issues. But in this study, urge incontinence was found to be a major risk factor for falls and fractures. So urge incontinence, the way that I think of urge incontinence is that if I'm standing here and I suddenly feel like I need to go to the bathroom, and then it suddenly comes on and I start racing and I get my hand on the doorknob, and before I can make it, I lose urine. So it's not stress incontinence, which is what happens when you sneeze or when you cough sometimes, but it's the minute the bladder gets full, you kind of don't have any warning. That's what urge incontinence is, a relatively common problem in older women, and this has been associated with an increased risk of fractures, presumably because when the woman is racing to get to the bathroom, she trips and falls and has an increased risk of falling. And the percentage of fractures attributable to this was estimated to be about 30%. So this makes us think that we should want to do what we can to reduce the chance of urge incontinence, not just because it's uncomfortable to have an accident, which it certainly is, but also because it can reduce the chance of getting a fracture. There are behavioral and medical therapies. You'll hear about that in a couple of weeks. We don't have direct evidence right now that reducing urge incontinence will reduce the risk of fractures, but I think it's an important message for me that I need to ask patients about urge incontinence, and for patients to be sure that they tell their physicians about urge incontinence, because incontinence has been described as the sort of the silent epidemic. Nobody wants to talk about it. Nobody wants to tell their doctors, and doctors have a lot of other things to do. We don't always ask about it. So I think we need to increase our awareness of this, not only because of it being a problem that women don't like, but also because of the fracture risk. Thiazides, we talked about with respect to this question already, that if you're on one, it might help your bones. Steroids, there are many reasons why a woman has to take steroids. Typically, we try to prescribe the lowest dose for the shortest period of time, and we try to give either local or topical steroids when we can. But if you're in a situation where your doctor is recommending steroids of some type, you can ask, do I really have to have this much? Do I really have to have it this long? Be sure that you're aware of the risk with osteoporosis. So exercise. We all know that exercise is important. So at one extreme, so ballet dancers, gymnasts who exercise to the extreme and stop getting their periods, that's associated with an increased risk of osteoporosis. The estrogen in their body goes down very low. Estrogen is very important for your bones, and if you don't have circulating estrogen, that increases your risk of osteoporosis. However, that's a relatively small problem. The bigger problem is people not getting enough exercise. So typically what my patients want to know is not, if I run an hour a day, how much will that benefit me, but what's the minimum amount of physical activity that I have to do? So there's a variety of recommendations about physical activity. The general recommendation from the American College of Sports Medicine and from a variety of other organizations is that all adults should get at least 30 minutes of moderate intensity physical activity on most, if not all, days of the week. And this is just sort of for general good health. Certainly more is okay, but this was sort of targeting a lot of people who weren't getting any exercise. For weight loss, which is not our topic today, but just because people ask about this, the recommendation is an hour a day. One thing specifically for osteoporosis to think about, Dr. Chesney was mentioning earlier how swimming is a great exercise. Swimming is a great exercise, but probably doesn't have It's not a weight-bearing exercise, and so probably doesn't have as much a positive benefit on the bones as perhaps walking or running might do. There are many positive reasons to do swimming, cardiovascular fitness. My kids are all on swim team. I'm a big advocate of swimming. But for osteoporosis prevention, it's probably not the most beneficial. So something that's weight-bearing, and in particular, something that is weight-bearing on the hip joints, because what we're worried most about are the hips. Also, it's been shown that walking for exercise has been associated with a 30% decreased risk of fracture. So there's a lot of reasons walking is good. So it's, burns calories, gets you going, weight-bearing exercise. But also regular walking is good for balance, is good for reduced falls. So lots of reasons why that probably is a benefit with respect to osteoporosis. And then I mentioned, very importantly, fall prevention. What can we do in the environment to change a person's risk of falling? And then what can we do medically? For example, are there medications that a person's taking? An older person on, a sleeping medication, for example, is a big red flag as a risk factor for falling. So let's talk a little bit about screening for osteoporosis, because people always want to know who should be screened, should I be screened, how often should I be screened, and what should I do after I'm screened. So bone density, which is what we do when we screen, we look at the bones, we look how dense they are, and that is the best predictor of having a fracture. As you might imagine, bone density of the hip is the best predictor of having a hip fracture, and hip fractures are what we care most about. The typical test that we use is something called DEXA, which is dual X-ray absorptiometry of the spine, hip, and body, and it's the most commonly used. All the studies that have assessed treatments for osteoporosis have used this as their standard. So the National Osteoporosis Foundation has published evidence-based guidelines for screening and prevention. I will also tell you a little bit about the U.S. Preventive Services Task Force, which I imagine Dr. Redberg might have alluded to last week. And they recommend screening and treatment alternatives. So the National Osteoporosis Foundation addresses screening and treatment. The U.S. Preventive Services Task Force really only addresses screening. The U.S. Preventive Services Task Force, when you hear a recommendation that they make, your ears should perk up. The reality is any organization can make a recommendation about anything. And there are lots of, there's expert opinion, and people think this and people think that. The U.S. Preventive Services Task Force is generally the most evidence-based set of recommendations, usually multidisciplinary, and based on whether or not there's enough evidence. And so I'm going to tell you some other recommendations, which are reasonable ones and are very congruent with the USPSTF. But I think in the future you'll probably hear more about the U.S. Preventive Services Task Force, and I would encourage you to listen carefully when you hear what they have to say. So the National Osteoporosis Foundation guidelines recommend that all postmenopausal women receive at least 1,200 milligrams of calcium per day, regular weight-bearing exercise, and avoid smoking and excess alcohol. So people, I think, kind of would have generally assumed that was the case. Adults over age 50 should receive 800 international units of vitamin D. We'll talk a little bit more. There's some new recommendations about vitamin D which are a little bit different from this, but this is what the National Osteoporosis Foundation recommends. And we should focus on fall prevention, because if you can prevent the fall, you can prevent the fracture. They also recommend considering something called hip protectors for high-risk women. So there was a study done probably 4 or 5 years ago now, looking at these special hip protectors that a woman could put on her hip, such that if she fell, she had the protector on, and so the chance of getting a fracture was less. So in this study, which was kind of innovative, the women put the hip protector on one hip and no hip protector on the other hip. And the idea for that, which was actually very scientifically sound, is that every woman served as her own control. So that presumably my left hip and my right hip are pretty similar, but the hip protector would be the one thing that would be different. So they didn't actually find that the hip protectors made a difference. There was actually a trend towards an increased chance of fracture in the side that had the hip protector on. But it was not statistically significant. The theory being, and I'm not supposed to move because I have to stay near the microphone, the theory being that if I had my hip protector on my left hip and I was about to fall, perhaps I might throw my left hip forward because that would be the protected hip, and that would be the reason that this hip had a slightly increased risk. In any case, not clearly shown to be efficacious, but relatively benign intervention, easy enough to do, just kind of a hassle for women. So something we can consider. So now the question is who to screen. So with any kind of screening test, and I imagine Dr. Redberg spoke about this last week, one of the primary reasons that we think about whether or not to screen is how prevalent is the disease in the population that I'm screening. So screening by definition is taking people with no symptoms and doing tests to determine whether or not they're at risk for a particular disease or have any precursors to that particular disease. So if you're going to screen a huge population, you need to be screening for something that's a relatively common disease. Now tonight we're not talking about cancer screening, but the big issue when we think about ovarian cancer screening, ovarian cancer is a very serious disease and it's often detected late, but it's thankfully very rare. So the main reason we don't recommend routinely screening for ovarian cancer is because it's rare. Okay, but we're not doing cancer. Back to osteoporosis. The first thing is that we need to think about who's at highest risk for osteoporosis. And the big driving factor, yet again, is age. Biggest risk factor is age. So for women over 65, their risk is high enough that it makes sense to screen all of them. And for men, the age is over 70. However, there probably are some younger people less than 65 who are at some risk that we might want to consider screening. So we can consider screening younger premenopausal women, younger men, if there's concern based on their risk factor profile. In the past, in the old days, in the hormone therapy at the time of menopause days for prevention, which is behind us now, but in those days, whenever a woman was coming in during the menopausal transition, we would say, you know, let's think about hormone therapy to prevent all these diseases, and one of the things that will help us decide is doing a bone density, so we can decide if you're at risk for osteoporosis. Now, and many women still come in saying, I'm going through menopause, is it time for my bone density? The reality is that most women at the time of menopause are at pretty low risk for osteoporosis because menopause does not happen at 65. What's the average age of menopause in the United States? 51. So most women at that young age are not at particular risk for osteoporosis. So if there's a particular risk factor, we can think about screening menopausal women, but generally it's probably not going to make sense because their risk at age 50 or 51 is pretty low. Now adults who've had a fracture after the age of 50, higher risk, although one could argue if they've already had the fracture, should probably just assume they have osteoporosis and treat them anyway. Or adults with some kind of condition associated with low bone mass. There are some medical conditions where people get what we call secondary osteoporosis, so they get osteoporosis because of their underlying medical condition. And then if a woman is taking estrogen for whatever reason and decides to stop, that might be a time to think about screening because the estrogen was helping her bones. A whole nother talk would be all the other things about estrogen, but if she was taking it, it was helping her bones, and if she's stopping it, then her risk for osteoporosis is probably increased. Now here's the U.S. Preventive Services Task Force. Again, the very evidence-based recommendations. If they don't have enough evidence, they basically say insufficient evidence. They sometimes recommend against screening for things. So they again recommend women age 65 and older. And then they say screening younger women whose fracture risk is equal to or greater to than a 65-year-old white woman who has no additional risk factors. So that kind of makes intuitive, theoretic sense if her risk is as high as a 65-year-old woman. But when you look at that, you kind of say to yourself, okay, well, how am I supposed to figure that out, right? I mean, it makes, you know, intellectual sense, but how do I figure it out? We'll talk about how to figure it out. Another question that frequently comes up is, when should the bone mineral density be repeated? Many of the things that we do in medicine or have done in medicine over the years, we get in this habit of doing things once a year. So pap smears, we did once a year forever and ever and ever. From now until you die, people got a pap smear forever. We learned 10, 15 years ago that you don't have to do pap smears that often, that you can do them every 3 years, and that heaven forbid you can stop in some women. But many people still are in the mode of pap smear every year. Mammography. Good evidence shows that mammography every 1 to 2 years is okay. But we have drilled it into women's heads for so long, got to have your mammogram every year. People have a hard time changing. So with any new test, people often think, I should probably get it every year. So let's think about when should the bone mineral density be repeated. So first of all, is she on treatment? And what are we going to do if she is? Very importantly is the previous result near a treatment threshold. So we'll talk later about drugs after we talk about the non-pharmacologic stuff. But generally you start drugs when a woman has osteoporosis, which is a bone mineral density less than, how many standard deviations? Negative 2.5, excellent, below the mean. So if the woman's bone mineral density was negative 2.3, you're probably going to repeat her bone mineral density sooner than if it was negative 1.4, because it's going to take her a lot longer time to get down to the negative 2.5. So if the woman's on treatment, a question comes up whether or not we need to monitor response to treatment. If I put you on a drug, do I need to check and see what's happening to your bones? Well, we don't really know that that makes any difference or that it's going to change anything, because if your bone mineral density went up, we're going to say, good, the drug is helping it. If your bone mineral density went down, we'll say, well, it probably would have gone down more if you weren't on the medication, and you're going to keep taking the medication anyway. So oftentimes, it won't change anything. There is some normal variation in the precision of these measurements, and the critical question always for this test and for many other tests, is it going to change our management? Are we going to do anything differently? So let's turn now. We talked about this idea of figuring out a woman's risk and figuring out if her risk profile puts her in that equal to a 65-year-old woman category. So let's talk about absolute risk assessment. So this is the WHO fracture risk algorithm. It's called the FRAX tool. At the bottom of the slide, you can see the website. You can also Google in FRAX, and it will bring it up for you. Similar to the Framingham approach, it calculates the 10-year probability of a hip fracture and the 10-year probability of any osteoporotic fracture. It includes femoral neck bone mineral density if you know it, but it can also calculate it without the neck bone mineral density. It can only be used in previously untreated patients, and it's been adapted for the United States. So this is a picture of the one. This actually is the British one, but ours is very comparable. It has a different color of the flag. Not different color, different arrangement. The colors are the same, I should say, but it had a different flag on it. So you put in age, sex, height and weight, which calculates body mass index, previous fracture, smoking, parental history, etc. You plug that all in, and it can tell you, here is your risk over the next 10 years of having a hip fracture and of having any osteoporotic fracture. So what is this useful for? So we'll talk more about the details of treatment, but if a woman has osteoporosis, we really need to think seriously about treating her. There's not a lot of debate that treating women with osteoporosis makes a difference. Women with osteopenia, there's a huge number of women with osteopenia, and there's a lot of debate about whether or not there are some women in that group who might benefit from treatment, because probably not all women with osteopenia should be treated, but maybe there are some who might benefit. So this is probably potentially useful in identifying those women. And the recommendation is to treat when there's a 10-year risk of hip fracture of greater than 3% and a 10-year risk of any fracture of greater than 20%. And when we order bone mineral density, so I send a patient for a bone mineral density, and I get back the report that says hip T-score this, vertebral T-score that, it's possible that in the future some of those reports might take into account the person's age and risk factor and say, with these results, here is a person's 10-year risk of fracture, and you may want to consider treatment A versus treatment B versus continued non-pharmacologic treatment. So let's talk now about treatment. So this is the National Osteoporosis Foundation, again, an organization making guidelines. So I told you first what they recommended about screening. They also have a set of recommendations about treatment. So the question is, first of all, who to treat. So anybody who has a hip or vertebral fracture. If I see a patient who has just had a hip fracture, there's really no point in my checking her bone mineral density to see whether she has osteoporosis, because she does. She had the hip fracture. She showed me that she had osteoporosis, so she just needs to be treated. If they've had other prior fractures and some kind of low bone mineral density, think about treating. T-score of negative 2.5, again, that's the official osteoporosis definition. Low body mass and some secondary causes, again, taking into account other risk factors. And low bone mass and this 10-year risk greater than 3% for a hip fracture or greater than 20% for any fracture. So again, this is sort of these women with osteopenia, but who seem to have a particularly high risk. Maybe they fall a lot, or other things that contribute to their risk. The American College of Physicians also has recommendations about who to treat. And again, when we talk about treatment, I think it's important to remind ourselves osteoporosis is a disease per se, but it doesn't really cause any problems until the woman has a fracture. So when we're treating to prevent the fracture that's going to come in 10 or 20 years, we want to be very careful about being sure that the person needs to be treated. Same thing with cholesterol. High cholesterol is a risk factor, it's not a disease. So not everybody with high cholesterol needs to be treated with drugs, but people who are particularly high risk really do. So I think when we think about treating, we want to be sure that we know who's really the most likely to benefit. So the American College of Physicians treat men and women who have osteoporosis and who've had fragility fractures. Again, if they've had a fracture, just go ahead and treat them. Consider pharmacologic treatment in people at risk. That's a very vague category. What does that mean? I mean, we're probably all at some risk for osteoporosis, right? And then figuring out what drug to use, if you decide to use drugs, should include the risks and benefits and the adverse effects of the drug options for each person. So we're going to start with some of the non-pharmacologic interventions, and then we will talk about the drug choices. So sort of getting back to the integrative approach, probably many of the non-pharmacologic interventions are things we should all be doing anyway, but in some situations they may not be enough and we may need to add on some drug treatments as well. So smoking cessation, we know people need to do that for a lot of reasons. Avoiding having too much alcohol. So, more than 3 drinks a day of alcohol increases osteoporosis risk. More than 2 drinks a day is associated with an increase in breast cancer risk. It's a little complicated because some amount might be associated with a reduction in heart disease, but of course, greater amounts, there's all kinds of complications. But in any case, avoiding drinking too much is good for your bones. Exercise. Okay, so exercise is really good for your bones while you do it. So if you're doing your weight-bearing exercise and doing it regularly, it'll increase your bone mineral density, which is all well and good. Unfortunately, when you stop, the effect does not persist. So continuing to get regular weight-bearing exercise over time, even walking, as I mentioned earlier, walking regularly, 30 minutes 5 times a week, has been associated with a reduced risk of falls and fractures. Probably not only about bone strength, but also about falls, but that's something that most people can do. So exercise works while you do it, but when you stop, unfortunately, the benefit goes away. Avoiding too much thyroid and hip protectors, which we talked about. Calcium. Okay, earlier today I was speaking at the UCSF Continuing Medical Education course on updating women's health, and there's all this new controversy about calcium alone versus calcium vitamin D. So here we go. Okay, so women should get the recommended daily allowance from diet, supplements, or both. In the ideal world, where we think about calcium, we think about vitamin D, and we think about all the vitamins and things we should get, in the ideal world, it would be wonderful to get all the things that we need from food, wouldn't it? However, most of us, unless we're really, really good about our dairy intake, and I will say I am not, do not get the amount of calcium that we need daily primarily from our food, and that's where this whole supplement thing comes up. Calcium and vitamin D together has been shown to be what we say is necessary but not sufficient. It seems to be important for helping your bone strength, but it alone, if a woman has osteoporosis, has not been shown to reduce the risk of fractures. I would love to be able to tell you that if you have osteoporosis, you don't need to think about medications and it's okay to just take your calcium and vitamin D and get exercise. Unfortunately, it hasn't yet been shown, that calcium and vitamin D, without some of the medications that we'll talk about, can reduce your risk of fractures. So even if a woman is getting adequate in calcium and vitamin D, she may still be at risk for fractures. So let's look at what can we get from our diet, and then I'll embark on the new calcium controversy. Okay, so if you were to look at your own diet, sort of think to yourself, what did I eat today? Did I get my calcium? So so you want to get 1,200 milligrams a day, 1,200 to 1,500. 300 milligrams is from 1 serving of dairy. Depending on the type of cheese, you can get 190 to 330 milligrams from cheese. Even though we say there's calcium in vegetables and there is calcium in some vegetables, that calcium is not all that well absorbed. So a serving of dark leafy vegetables give you about 100 milligrams. So, there's lots of other details, but in the big picture, I'm not going to take a poll, but I imagine many of you probably didn't get 1,200 milligrams of calcium today. I can assure you I did not get 1,200 milligrams of calcium today. I did have my latte this morning, but that's about it. So if you're going to take supplements, so calcium, I'm often asked about calcium citrate versus calcium carbonate. Calcium citrate is easily absorbed whether you're fasting or whether you're eating, so you don't really have to think about when you're going to take it. Calcium carbonate is cheaper, but it's less well absorbed. If you're taking a proton pump inhibitor, which is Prilosec, Prevacid, all those antacids, the big purple pill, whatever people call those, or any kind of Tagamet, any of those things, if you take those, then it's harder to absorb things. If you're taking more than 500 milligrams a day as a supplement, you need to take that in divided doses. Generally, what I recommend to people, probably most of us get about 500 milligrams a day. Maybe some of you are better. So that usually means you need to take 500 milligrams twice a day as a supplement. Okay, so there's big meta-analysis done. Recently, a meta-analysis is a way of combining lots of different studies together to sort of summarize and see what kind of results you get. And these meta-analyses showed that women who took calcium alone seemed to have a somewhat of an increased risk of having a heart attack compared to women who didn't. There's been a lot of controversy about this study. It only looked at women who took calcium. It didn't look at women who took calcium plus vitamin D. And there's some debate about whether it has to do with diet versus supplements. But this is something that's been in the news a lot now. A couple of other studies have suggested that maybe if you take it with vitamin D, that it might actually be beneficial with respect to heart disease. So the jury is still out, but I want you to be aware of the fact that this is out there. At this point, I think there's really no reason to recommend to a woman to take only calcium. We're going to talk in a moment about vitamin D, but for most women, recommending to take calcium plus vitamin D probably makes sense. The association hasn't been seen with calcium and vitamin D. Okay, vitamin D. This is the in thing these days, vitamin D. I will take a poll right now. How many people in this room have had your vitamin D levels checked? I knew it. I'd say about 80%. So probably 4 or 5 years ago, C-reactive protein was kind of the in thing. Vitamin D, or actually 25-hydroxyvitamin D, which is what we measure, has gotten a lot of attention. Every week there's a new study showing that vitamin D is associated with some new health condition. It's associated with fatigue, it's associated with depression, it's associated with this kind of cancer. Again, association versus causation. Vitamin D clearly has a role in keeping your bones healthy. Low vitamin D is not good for your bones, and it has been shown that vitamin D supplementation helps your bones. But its association with all these other things that it's supposed to be good for is not clear. As you just showed me, 25-hydroxyvitamin D levels are very widely ordered, and deficiency, which I'll say in quotes, and we'll talk a little bit about what that means, has been very widely treated. There have been a lot of guidelines out there up until a few months ago when the Institute of Medicine published some new guidelines. All of the guidelines were based on if your level was at a certain low level, you should treat it to get it up to what was defined as an optimal level based on the number in the blood, but not necessarily based on some positive health outcome. So vitamin D deficiency is common in older adults, homebound individuals, women admitted with a hip fracture. The association previously between vitamin D and fracture risk was inconsistent, and there's a lot of things that could affect it. Vitamin D is involved in kidney function, muscle strength, and estrogen receptors. So the questions for us with vitamin D: what's the association between vitamin D level and fracture? Does vitamin D prevent fracture? When should vitamin D levels be checked? This is the $100,000 question. Should we just tell everybody to take vitamin D, or should we be checking all the levels? In this audience, everybody's getting their levels checked. And then when and how should vitamin D supplementation be given? So this study looked at the association between 25-hydroxyvitamin D level and hip fracture. And you can see that if you look at the quartiles from the lowest to the highest, those with the lowest quartiles of vitamin D level in their blood, or 25-hydroxyvitamin D, had the highest risk of fracture compared with those with the highest in their blood, which was the reference group. And this was what we call, the trend was significant, which is what we call a dose response curve, so that the lower your vitamin D, the higher your fracture risk. So this linear association has suggested this dose response effect. There was no difference by age or geographic region. There's been a lot of concern that in certain places that don't see a lot of sun during the winter, that it would be more of an issue in those places. And so this study showed us that these low levels of 25-hydroxyvitamin D, which is the metabolite of vitamin D that we measure in the blood, can identify women at high risk for hip fracture. But then the question was, whenever you see an association, the next question is, if I change that, if I give a woman vitamin D, does that reduce her risk of fracture? So this was, again, a meta-analysis. A meta-analysis is a way of combining lots of different studies, many of which are too small enough to give you the conclusion individually, but combining them together to see if you can draw any conclusions. And these studies evaluated vitamin D supplementation and reported at least one fracture. They had to be relatively rigorous studies, which are what we call double-blind, so that the investigator and the patient don't know what they're getting. They had to follow the patients for at least a year, and they had to have some measure of whether or not the patient was actually taking the vitamin D. And they could take either vitamin D3 or vitamin D2. They had 12 included trials, and they found that vitamin D doses greater than 400 international units a day. I should ask you all what doses of vitamin D you're taking, but we'll get there. This is not a very high dose compared to the dose that is often recommended. This reduced non-vertebral and hip fractures, but lower doses did not. The addition of calcium didn't really seem to make any difference. So again, going back to this question of how do calcium and vitamin D interact? Is vitamin D the thing that makes the big difference? Is it vitamin D with calcium? Is calcium alone not a good thing? And the anti-fracture efficacy was higher with the higher level of 25-hydroxyvitamin D that you got that they saw in the blood. So the impact for us was that daily vitamin D supplementations can reduce fracture risk. What this didn't answer was what's the value of other added therapies, such as calcium, bisphosphonates, which we'll talk about, which are the first-line drug treatment. And another question is, at what age should supplementation start? When should women start thinking about taking vitamin D? So this study was published just this past year, looking at high-dose annual vitamin D. One of the concerns about what some of the mixed results of vitamin D was whether or not if people didn't really take the vitamin D, you didn't really know if it made a difference. So these investigators decided to solve this problem. This study was done in Australia, had about 2,000 women, and they gave this huge dose, 500,000 international units once a year. So they don't really have to worry about adherence, right? You don't have to check if the person's taking it every day. They come in, they take their annual dose, they go on their way. They actually found that vitamin D annual high dose was associated with an increased, not a decreased rate of fractures. And there was an increased risk of falls in the first 3 months after the vitamin D dose. So suffice it to say, this was not a success. I think you can conclude that this is not recommended. But the question really, since none of you are presumably taking that high of doses, although I bet there are some of you who take or have taken the 50,000 international units once a week for 8 weeks. I will not take a poll, but it was a standard recommended. I see some head nods. So in any case, I will not point fingers. So we don't necessarily know about the impact of lower doses or less frequent doses, more frequent doses. So vitamin D insufficiency, the trends are increasing. This may be partly related to more cautious avoidance of sun and more use of sunscreen, but the majority of non-Hispanic blacks and most Mexican Americans have some vitamin D insufficiency. So here again is the question, should we measure 25-hydroxyvitamin D, or should we just encourage all women to take vitamin D, to take calcium vitamin D, to get some amount of sun exposure? It's being measured very widely, as many of you can see, but an alternative approach would be to just make sure everybody gets their amount of vitamin D without having it measured. And maybe we should consider measuring it in people who are particularly high risk, those who are homebound, malabsorption in a nursing home, or individuals who have osteoporosis. So these recommendations that have been floating around about vitamin D for probably the past 4 or 5 years have recently been sort of supplanted by some new evidence-based recommendations. So the recommendations that were out there for a while had to do with achieving a certain serum level, and depending on how low you were when you started, taking different amounts of vitamin D to get there. So the people who had really low levels were encouraged to take this high dose once a week of 50,000 international units. The idea being that we needed to get you to this adequate level, even though we didn't really know how important it was to get you there. There was no clinical association. Or probably, since we weren't measuring vitamin D levels like this 5 or 10 years ago, if you have a level of 10, you may have had a level of 10 for 20 years. Do we really have to get you to a level of 30 in 2 months? Probably not. Anyway, recent publication of New Institute of Medicine guidelines for dietary calcium and vitamin D. The talk I gave earlier today to a group of physicians, somebody was saying, you know, how come we're not doing this? I said, well, you know, this was only published probably within the past 3 to 4 months. It takes a long time for things to sort of get into the mainstream and physicians to change our practice. We kind of have a hard time doing things differently. We get in our little way of doing things, and it takes a while. So the new recommendations are much less aggressive than these things that have been floating around for a while. So for women aged 9 to 70, it's recommended to get 600 international units a day. The recommendations that had been floating around were 1,000 to 2,000 international units. For women over age 70, 800 international units, and the upper limit should be 4,000 international units a day. And then this, looking at the goal of how high your 25-hydroxyvitamin D level in your blood should be. For quite some time, we've been aiming for this goal of 30, and these new recommendations said, you know, there's really no evidence that we need to aim for this goal of 30. Let's aim for the goal of 20. So that's the new vitamin D recommendations. So now we're going to turn to some of the medication options for treatment of osteoporosis. So just, you know, again, to remind ourselves, calcium and vitamin D, you know, there's a little bit of controversy, but even if we think that they're beneficial, for women with severe osteoporosis, they don't appear, with osteoporosis, not osteopenia, they don't appear to be enough. Exercise is great and is wonderful and is very important, but also probably is not enough to get a woman out of the osteoporosis range into osteopenia. And so for many women, it does make sense to think about medications. So what are the FDA-approved therapies? And then we'll talk about each of them. So the first one is estrogen, and we'll talk about that very carefully because you don't take it only to prevent osteoporosis, but if you're taking it, it might help your bones. Bisphosphonates are the standard drug of first choice for osteoporosis. Calcitonin, there's a category of drugs called the selective estrogen receptor modulators. We'll talk about those. And finally, something that's naturally produced in your body, but that given in a slightly different way can help your bones, is something called parathyroid hormone. Okay, so estrogen. Estrogen, you know, we've gone back and forth on estrogen. We know now that there are many risks to the long-term use of estrogen. We do not prescribe estrogen primarily to prevent disease the way that we did many years ago. However, one thing that estrogen does is help the bones. So observational studies have shown a 50% reduction in hip and other non-spine fractures. And in 2 randomized controlled trials of women who had vertebral fractures, it reduced the rate of new fractures in half. And the Women's Health Initiative, which, as you know, is the biggest trial in the history of our country, has given lots of information. Most of the information that we have about the pros and cons of estrogen came from that study, significant reduction in fractures. However, we don't prescribe estrogen primarily to reduce osteoporosis risk. However, I bet many of the women in the room could tell me that there is one potentially good reason to take estrogen. Anybody want to tell me? Hot flashes. So yet again, a whole another topic. There are lots of now alternative drugs and recently FDA-approved drugs for hot flashes, many things we can try. The bottom line is that estrogen works the best for hot flashes. So for many women who have significant hot flashes not helped by other therapies, estrogen really helps. And it is the most effective medication for hot flashes. So if a woman is having significant hot flashes and is taking estrogen, we can rest assured that her bones are okay during the time she's taking estrogen. But we don't want to prescribe it primarily to help her bones. The U.S. Preventive Services Task Force does not recommend the use of estrogen for the treatment of any chronic conditions, but some women may be taking it for other reasons, primarily hot flashes. So now we'll turn now to the drugs of first choice. This category of drugs is called the bisphosphonates. The 4 approved ones are alendronate, risedronate, ibandronate, and zoledronic acid, otherwise known as Fosamax, Boniva, several other ones as well. These are sort of the standard drugs for osteoporosis. They have not been compared to each other, but they have all been compared to placebo, and very importantly, they have been shown to reduce the risk of fracture. Whenever you hear about a new osteoporosis drug, it's interesting to know that it increases bone mineral density. But what do you really want to know? What you really want to know is, does it reduce the risk of fracture? So studies really need to look at whether or not fracture is reduced, not just what we call the intermediate outcome of whether or not you reduce the bone mineral density. So they bind to the cells in the bones that break the bones down. They increase bone mineral density by 3% per year. And they've been shown in multiple studies to reduce the risk of fracture. And that's why they're considered the drugs of first choice. So they're poorly absorbed. They have to be taken first thing in the morning on an empty stomach. In the old days, my kids always say to me, Mom, you know, in the old days when you were young, I'm talking about like in the old days of medicine, which is not quite as old, but in the beginning of these drugs, people had to take them every day. And it was kind of a big deal. You had to get up first thing in the morning, drink your glass of water, remain upright, not lie down, not take any other medications. They kind of got revolutionized when you could take them less frequently. So most of them now are once a week. However, Boniva has once a month. There's an IV infusion of once a year. So having to deal with this standing up straight, not going back to bed right away is kind of easier to tolerate if you only have to do it on Tuesdays than if you have to do it every day. When you look, we also have a fair amount of long-term data on these drugs. So with any new drug, you'll see a trial that shows you that at 2 years or 3 years, you saw this outcome. But you kind of want to know, what do we know about the long-term safety? Because once you start taking this drug, you don't just take it for 2 years, right? When you start taking this, it's going to be something you're taking long-term. So you want to know, what do we know about long-term safety? And there appears to be continued therapeutic effects and safety with long-term use. However, once you stop it, it helps build up the bones, but once you stop it, there is some loss of the effect. As I mentioned, the less frequent administration of the medication has really improved compliance. Boniva once a month and the yearly zoledronic acid. Now, as with any drugs, there are potential side effects, and people hear about them, so I feel like it's important that we talk about them to sort of put them in perspective. Osteonecrosis of the jaw is an important one, and this increased risk of femoral shaft fractures. Several years ago, I was actually at the dentist getting my teeth cleaned, and I heard the person in the chair next to me ask the hygienist if she should stop her Fosamax because of the increased risk of osteonecrosis of the jaw. And thankfully, I was not able to speak because I was having dental work done, but I was trying to hold back because I would have had something to say. In any case, what do we know about osteonecrosis of the jaw? So in the big picture, it's rare. It's much more common with the potent bisphosphonate use, typically in people who are treated for cancer who get the intravenous bisphosphonates. 94% of people who have gotten it have been treated with the intravenous forms, and only 4% of the cases have osteoporosis, and about 60% are caused by tooth extraction. The risk factors are medications, in particular chemotherapy and steroids, and dental extractions and periodontal disease. The goals are early identification and conservative treatment, and thinking of the big picture, important to remind ourselves that the risk in those treated for osteoporosis is very low. It's probably less than 1 in 100,000 patient years.
What is osteonecrosis?
So osteo means bone, necrosis means death. So it's a jaw problem where the bone basically dies, and it requires significant oral work. So that's one of the side effects that's kind of gotten a lot of press. So I wanted you to know a little bit about that. Another side effect of these that has gotten a lot of press recently is this increased risk of certain types of fractures in people who have osteoporosis. So first, there were several what we call case series. A case series is, at my hospital, I saw a bunch of people with this, and I'm going to write about it. So I saw 10 or 12 people with this problem that had an increased risk of a certain type of fracture if they were taking osteoporosis medications. So first of all, it's important to remind ourselves this particular type of fracture, it's called a subtrochanteric fracture, based on its location, makes up about 2 to 4% of all hip fractures, so a very small percentage. And also, when you do a case series of the things I saw at my hospital, people that came in, it doesn't tell us anything about how common this is in the population. So then if you looked at population-based registries, you would say they saw that fracture rates were higher in people who took alendronate. So then you ask yourself, let me think, who are the people who take alendronate? They have osteoporosis. They are at high risk for fracture. So that doesn't give us as much information as we might want either. So in order to get at this question of how common is this and do we really need to worry about it, there was a reanalysis of data from 3 of these big trials for the bisphosphonates. So as I told you, we have several trials for the bisphosphonates showing that they reduce fracture risk. So the investigators went back, got the information, and looked for this particular type of fracture to see what they saw. So in these trials, over 14,000 women, there were a total of 284 hip fractures. So these were women with osteoporosis in these trials, high risk for hip fracture. That's why they were in the studies. Of these 284, 12 of them were this worrisome fracture. So 12 out of 15,000 women were these subtrochanteric fractures. When you looked at how likely they were to be associated with the drug, the relative hazard is basically the relative risk compared with placebo for alendronate in the FIT trial, 1.03. The confidence interval, as you probably know, looks at how likely this result, what's the spread for this result. If that confidence interval includes 1, then the likelihood is basically that it's the same. As you can see, a huge confidence interval. Relative hazard here of 1.5, again a huge confidence interval that crosses 1 in one of the other trials, and a relative hazard of 1.33 for those women who continued on with alendronate in an extension trial, again with a huge confidence interval. Basically no association in these larger trials. And as you can see, when you look at the population prevalence, very, very rare fracture. So this particular fracture of the subtrochanteric or diaphyseal femur was very rare, even in women who were on bisphosphonates up to 10 years. And there was no significant increase in risk, although, as you saw, there were these very wide confidence intervals, which is because there were so few events. So even if there is a tiny risk of this unusual fracture associated with bisphosphonate use, this must be weighed against the population benefits that we've seen with an overall reduction in hip fractures with bisphosphonates in women with osteoporosis. So with any drug that we take or we consider taking or think about, there's always potential benefit and potential risk. There is no drug that is risk-free, and that's why we always want to think carefully about any drug, particularly a preventive drug. But in the big picture here, many studies have shown a significant reduction in fracture, and these potential negative effects, if they're there, appear to be quite small. So an important question that comes up, if I take bisphosphonates, how long do I have to take it? Can I take it for a few years and then stop? And this is always a challenging thing to think about, because let's say we screen a woman at 65 and she has osteoporosis and we start a drug and she takes it for 5 years when she's 70 and she stops it. Her biggest risk for hip fracture is based on age, so she's going to get her hip fracture when she's 85, probably. That's, I mean, the average age is in the 80s when women get their hip fractures. So if we take her off her drug at 70, then what are we doing for her hip fracture at the age of 85? So there have been some studies looking at what happens if you stop the alendronate. Do you keep the benefit? So women who stop the benefit, who stop the alendronate for 5 years, have a decrease in bone mineral density in the hip and in the spine, as you would imagine. But it doesn't quite go all the way back down to where it was before they started treatment, which might be good. There's a lower risk of clinically recognized vertebral fractures for those who continued on the drug. So if you continued on the drug, you had less vertebral fractures. So probably for some women, discontinuing alendronate therapy after 5 years may not increase fracture risk. And those who are at high risk for fractures may benefit from continuing more than 5 years. And that makes, theoretic sense. Some women you can stop, some women you can't. The high risk ones you should continue. The question is, how do you figure out who those women are? So bisphosphonates can reduce the risk of vertebral fracture and hip fracture in women with low bone mineral density. They may not reduce fracture in women without osteoporosis. You can take them less often. They have the best evidence of any treatment. Maybe after 5 years, some women may stop, but I have no idea how to figure out who those women are. So who can you stop? How do you monitor those people? How long do they stop? There's some thought that maybe you can go on for 5 years, off for 5 years, on for 5 years. Nobody really knows the answer to that, but this is a question that frequently comes up. Can I stop? So let's turn now to another class of drugs. Raloxifene is the typical example. These are called the selective estrogen receptor modulators. So the idea is we used to think estrogen was great. Then we found out estrogen had some bad properties: stroke risk, blood clot risk, breast cancer risk. We thought it helped heart disease, but doesn't really. So the idea of these drugs was to sort of keep whatever positive effects of estrogen remain, which seem to be osteoporosis prevention, and minimize any of the bad effects. So let's try to get rid of the clotting risk and the stroke risk and all those other things. So that's kind of the theoretic idea. Estrogen alone increases the risk of cancer of the uterus. Maybe these new drugs won't cause that to happen. So raloxifene, which is the prototypical selective estrogen receptor modulator, they're also known as the SERMs, reduces vertebral fracture, but it hasn't been shown to reduce the risk of hip fracture. So just like I told you a moment ago, you don't really care if it only changes bone mineral density. You want to know if it changes fracture. What you really want to know is, does it reduce the risk of hip fracture? Hip fracture is the thing that people die from, that people have significant consequences from. Not all vertebral fractures have consequences. So raloxifene hasn't been shown to reduce the risk of hip fracture, and it didn't quite turn out to be everything that was expected. There was still a risk of thromboembolic events. That means blood clotting, so clots in the legs, pulmonary emboli, which is a clot going to the lung, which is a pretty big deal. That continued. Tamoxifen you've probably heard about. You'll hear definitely more about next week with breast cancer prevention. Raloxifene seems to have a similar effect with respect to breast cancer prevention, and it doesn't do anything bad to the inside of your uterus. So it kept some of the positive effects, but some of the negative effects still stayed there. Calcitonin is a medication that's FDA approved for women who are at least 5 years postmenopausal. The potentially nice thing about it, it's a spray that women squirt in their nose. It's been shown to increase bone mineral density, reduce vertebral fractures. Again, hasn't been shown to reduce hip fractures. May have some kind of an analgesic effect in women who've had a vertebral fracture, which can be associated with a lot of pain. And oral calcitonin has been FDA approved and is in some studies, so stay tuned for that. Parathyroid hormone is another thing that's gotten a lot of attention. So in our bodies, we have our thyroid gland at our neck here, and around our thyroid gland we have 4 little tiny glands called our parathyroid glands, and they are involved in calcium metabolism in our body. Usually the parathyroid acts in a certain way where it gives out sort of pulsatile, periodic amounts of parathyroid hormone to regulate our calcium. If you have an overactive parathyroid, what's called hyperparathyroidism, that actually causes you to lose bones, lose bone density. However, this parathyroid hormone medication, which is given in a pulsatile way as a daily injection, which is one of the major potential bad things about parathyroid hormone, you think about once a week pill versus everyday injection, not too much choice to make there. But in any case, if you give it in a pulsatile way, it seems to build up the bone rather than break it down. It's been shown to reduce vertebral fractures by a lot and non-vertebral fractures by a lot after 18 months. And it's been FDA approved for women who are at very high risk for fracture. So far, its safety and efficacy has only been shown for 2 years. And so if a woman is treated with this, and it's usually used for women who have not done well with other therapies or who have gotten fractures while on other therapies, it's usually recommended to be only used for 2 years and then to go back to some other drug afterwards. And as I mentioned, the major downside is that you have to have a shot every day. Parathyroid hormone versus bisphosphonates, how do they compare? They haven't been compared head-to-head in a trial that evaluated fracture outcomes. They've only each been compared with placebo. So each of them has been shown to be better than placebo, but they haven't been compared to each other. Parathyroid hormone has been shown to increase bone mineral density more, but again, we want to know if it increases fracture protection more, not just only bone mineral density. As you can imagine, it's much more expensive and much more of a hassle, and we still have a lot of questions about the long-term safety. So certainly a lot more information about the bisphosphonates. And then what do you do after the 2 years? So if a woman takes this because she either wasn't able to tolerate or didn't do well on other medications, you give it to her for 2 years, then what if she has no other medications left? There is some bone mineral density decline after stopping it. Some anti-resorptive therapy should probably be added after you stop it. What that medication should be, we don't necessarily know. So in summary, it has a big impact on bone mineral density, big impact on vertebral fractures. We don't know necessarily about hip, long-term safety issues, daily injection of an expensive drug, and probably it should be reserved for use in people who have severe osteoporosis in whom other treatments have failed. I'm going to close with just sort of a few what I call emerging issues in osteoporosis, just some sort of new associations that have been seen that we can think a little bit about. Depression in osteoporosis, diabetes in osteoporosis, a medication called tibolone, and a medication called denosumab. So depression and osteoporosis, is there an association? One wouldn't necessarily think that there would be, but this was a baseline measurement in 133 women who had premenopausal women who were enrolled in a study of bone turnover. And the prevalence of low bone mineral density, so this was, osteopenia, osteoporosis, was higher in women who had a history of major depressive disorder. And depression was associated with low bone mineral density. Now moving from depression, moving into the treatment of depression, because these things are sort of connected. So the selective serotonin reuptake inhibitors are the most commonly used antidepressant medications: Prozac, Zoloft, Celexa, Lexapro, usually the first-line choice for people for whom we prescribe medication for depression. In the study of osteoporotic fractures, which I mentioned earlier, but a very important study done here out of UCSF, where over 9,000 women in 4 different cities across the nation were followed forward in time to learn about risk factors for osteoporosis. And many of the information that we have about osteoporosis came from this study. So in this study, bone mineral density was decreased more in SSRI users than in non-users. But somebody who was thinking might say to themselves, well, you just told me it was about, depression, and now you're telling me it's about this drug. Maybe it's just women who are depressed. However, they also looked at another commonly used class of medications, something called the tricyclic antidepressants, which are older class of antidepressants that were used, and they didn't find any difference between the TCA users and the non-users. So it seemed to be specifically only related to the SSRIs. And it appeared to be independent of the severity of the depression. Among 90,000 women in the Women's Health Initiative, depressive symptoms were not associated with bone loss, and antidepressant use was not associated with a bone mineral density reduction, but it was associated with an increase in vertebral fractures. So, what do we do with all this? So maybe when we're thinking about risk factors, and we started out at the beginning with a huge number of risk factors for osteoporosis, maybe we should think about depression and or SSRIs as we think about risk factors for depression. Maybe we should consider being more cautious about using these medications in women who have osteopenia or osteoporosis. And maybe we should consider screening appropriate women who have depression for osteoporosis sooner than we might otherwise. So these are sort of emerging issues, not kind of standards of care, but just a few things to let you know what's on the horizon. Diabetes, so young women with type 1 diabetes, which is the juvenile diabetes, insulin-dependent diabetes, have lower bone mineral density than age-matched controls. So again, it brings up the question, should we consider type 1 diabetes when we're assessing osteoporosis risk? A couple of new associations, bisphosphonates. So as I mentioned, bisphosphonates, first-line drug for treatment of osteoporosis. In 2 observational studies, they've been associated with a lower risk of breast cancer. Again, you wouldn't prescribe a bisphosphonate to reduce breast cancer risk, but maybe if you're taking a bisphosphonate, it might also help reduce your breast cancer risk. Proton pump inhibitors, that's Prilosec, Protonix, the standard antacid medications that many people take that have been over the counter probably for about 5 years now. They were not associated with hip fractures, but they have been associated with some other fractures, and there's been some controversy about their role in association with fractures over the past couple of years. New therapies on the horizon, again, sort of not ready for prime time, but denosumab is a human monoclonal antibody. Monoclonal antibodies bind very specifically to different things in the human body and are used in a lot of different diseases. And they specifically bind to these cells which are called osteoclasts, which are the cells that break down bone. Osteoblasts are the cells that build up bone. And this was a study in over 7,000 women where they got this medication subcutaneously every 6 months, and they found a significant reduction in new vertebral and hip fracture. So again, if we have a standard treatment for osteoporosis, which is bisphosphonates, ideally we would like to see this compared with that standard treatment. And it hasn't been shown compared with standard treatment, nor is it FDA approved. So in summary, osteoporosis prevention: avoid or quit smoking, regular weight-bearing exercise, calcium and vitamin D, and a focus on fall prevention. Measure bone mineral density in women aged 65 and over, and consider risk factors in measuring bone mineral density in younger postmenopausal women. And the FRAX tool is something that can give you a more specific estimate. Any fracture increases the risk of subsequent fracture and mortality, and the WHO FRAX tool is useful for absolute risk assessment, especially in women who have low bone mass but not yet osteoporosis. The bisphosphonates and estrogen have been studied the most extensively and should remain the first-line agents. And I say that, with my whole caveat about estrogen, that if you're taking it, it helps your bones, but you don't want to prescribe it or take it just to help your bones. Raloxifene, calcitonin, and parathyroid hormone should remain second-line agents. Next week, you'll hear more about raloxifene, but it has indeed been associated with reduction in breast cancer risk, and in some women who are at high risk for breast cancer might be an additional thing to consider in terms of breast cancer. Calcitonin may be an option for women who want an analgesic effect or who can't tolerate other medications. And parathyroid hormone is probably sort of a last resort for people who are really unable to take other medications or for whom other medications have not been helpful, and the use of it should be limited to 2 years. Thank you very much. And I'm assuming we have some time for questions. Yes. So the question again is, how long should you stay on the Fosamax, and maybe should you take a bone mineral density at some point to decide if you can go off it? So again, the biggest risk for getting osteoporotic fracture is getting older. And so there are lots of ideas about maybe you could go off it for a while and go on and go off. Maybe some women can stop. We don't necessarily know how to figure out who those women are. Even if you did a bone mineral density and saw that it was improved, we don't actually have evidence at this point that therefore it's okay to go off and go back on in 5 years or not go. So there is a lot of interest in the idea of not having to take the medication forever, but it's challenging because it's hard for me to think about stopping a medication at the same time that your risk for the disease is increasing. It makes more sense to me to think about stopping a medication if your risk for the disease is decreasing, but as time marches on, your risk is going up, and maybe at some point we'll be able to figure out which women can stop medications and restart, but right now we don't really have a good way of figuring that out. So the question is about magnesium with calcium. Magnesium is involved in calcium absorption and is involved in calcium metabolism. We don't actually have any studies assessing the added impact of magnesium and calcium on fracture risk. Magnesium is often in calcium pills, in calcium tablets, but in terms of exactly how much you need and its added effect on fracture risk, we don't really know. Yes, in the back? How much sun exposure to have an adequate amount of D? Not very much. Probably 15 minutes a day, and you don't even have, it's not like even 15 minutes a day of lying in the sun. It's like being out and about, walking around, doing your thing. So you really don't need all that much sun exposure. And how much that's contributed to this, quote-unquote epidemic of vitamin D insufficiency. I think part of the epidemic of vitamin D insufficiency is that we are now measuring it. Because when we didn't measure it before, we didn't know. So I had a patient recently say to me, well, my vitamin D level was never low before, but last year it was. And I thought, why it was never low before? Because nobody ever checked it. So you can't as much assess an epidemic when the thing isn't being measured all the time. So sunscreen may be part of it, but a little difficult to figure out how much. Yes. So the question is, how many women get osteopenia or osteoporosis, and how many get to age 65 or 70 and not have any of those conditions? So about 50% of women will develop osteoporosis over time. The lifetime risk of fracture, I think any fracture was 33%, and lifetime risk of hip fracture, I think, was about 10%. So there is a subgroup of women who won't ultimately get it. But it's hard to predict who those women are, and lots of women do get it. But it amazes me sometimes when I'll see like a 90-year-old woman and we'll do her bone density and it's normal, and she looks thin and frail, and I would have thought she would have had osteoporosis. Margaret? Yes. Not all women will. If the reality is, if all women were going to develop osteoporosis, we wouldn't need to screen, right? If we could just say every woman in this room, by the time you're 75, you're going to have osteoporosis. We would just put Fosamax out there for you when you turn 75, right? We would hand it out on the way up. So, but I mean, if indeed everybody was going to get a disease, there would be no reason to screen for it. So we screen for it because not everybody will get it, and some women won't. Can we figure out who those women are, and can we figure out if you have the good risk factor profile, will you not get it? You know, unfortunately, not entirely. We all have probably known people who have chain smoked forever and ever and who are healthy as a horse, and we've known unfortunate people who developed lung cancer at a young age or heart disease at a young age and never smoked. And so a risk factor increases your chance of something, or a protective factor decreases your chance, but neither of those things guarantee that you will or won't get something. Yes? So the question is heredity a risk factor? Unfortunately, age is a risk factor for everything, and heredity is a risk factor for everything. So, and those are what we call euphemistically non-modifiable risk factors, right? You can't do anything about getting older, and you can't do anything about your age. But yes, indeed, and actually in the FRAX tool, when you look at that later, you will see that parental history of a hip fracture is a significant.
You say you could not take that test if you've been treated?
It does. If you're on treatment, it's hard to know what to do with the results. If you're on a treatment. Because the results have been, this predictive tool has been used in a population of people who aren't on treatment. Yes? So the question is about spacing of calcium throughout the day versus megadose. So a couple of issues. The spacing throughout the day is calcium, and the megadose was vitamin D. So two different issues. So one of the things about vitamin D, and one of the things I remember from medical school, is that there are 4 fat-soluble vitamins, A, D, E, and K. So you probably all heard, like Linus Pauling and vitamin C, you can have as much vitamin C as you want, and you just pee it all out, right? It's a water-soluble vitamin. If you don't use it, you know, they used to say you have very expensive urine. So things that are water-soluble, you don't use it, they go out. Things that are fat-soluble, which is vitamins A, D, E, and K, stay in your fat. So the vitamin D study with this once-a-year megadose vitamin D was vitamin D, which stayed in the fat stores and presumably, you know, had its effect over time and even had some worse effects in the first 3 months. Whereas calcium is a mineral, not a vitamin. And in order for it to be absorbed, needs to be given twice a day. Now, one of the theories, and I didn't get into this with this whole calcium and increased risk of mortality thing, is that calcium supplements are a little different from calcium in your diet, because calcium, if you have a little bolus of it, will act differently than if it's in your diet and it gradually goes through your system. But that's a theory that's still trying to be sorted out. But it has to do with the fact that they're two different items.
Thank you so much, Dr. Walsh.